Thank you for joining us today for today's webinar, Reframing Surgeon Wellbeing, How the Trauma Model Informs Approaches to Wellbeing Solutions at Systemic Levels, sponsored by the American College of Surgeons Surgeon Wellbeing Program. We encourage you to ask questions and have a robust discussion about reframing surgeon well-being using the trauma model and various issues, factors, and drivers at all levels of individual and organizational well-being. Please use the question and answer box to submit questions throughout all of the presentations. A recording of this webinar will be made available on demand. We encourage you to share it with your other colleagues. We are excited and pleased to welcome our presenters for today. Dr. Liberis is running late for joining us, so we will be having Kathleen McCann, ACS staff, fill in as moderator for us right now. So I will go ahead and turn the webinar over to Kathleen to introduce our first panelist.
Thank you. We're happy to welcome Dr. Mary Brandt, Professor of Surgery at Tulane University School of Medicine. She's an internationally recognized pediatric surgeon, clinical researcher, and educator. Dr. Brandt brings an expertise in physical wellness, compassion fatigue, work-life balance, and the art of medicine to our panel today, speaking on applying trauma model to reframe how we view and address surgeon well-being. Welcome, Dr. Brandt.
Well, I am delighted to be here, and from New Orleans, I wish everyone a happy Mardi Gras. So I think lots of times for us as surgeons, we struggle a little bit with wrapping our arms around what is clearly an epidemic and a life-threatening epidemic. And what I want to propose to you today is a little bit of a different paradigm. So not a how-to, but a how to think about this. And I want to use a model that we're all very familiar with. So let's start off with what exactly is burnout? Do we really understand this diagnosis? And if we've been working on this for over 15 years, which is the case, why does it sometimes feel like things are getting worse instead of better? And when I thought about this, it was like, well, maybe we just do need a different paradigm. And we have one, I think, that we can use to basically apply the way we think about the world as surgeons, and particularly trauma surgeons, to this problem as well. So, big paraphrase, right? But in general, the techniques we learn in ATLS to deal with an injured patient is, first question is, are they dying now? And how do I intervene right now to save this life? And then we go on to what caused the injury? How bad is it? What do I need to do to stabilize it? And then finally, what do I need to do to heal it? And I will add another line, which you'll hear about, I think, in a lot of the other talks, which is, how do we prevent this from happening in the first place? This is a dangerous epidemic. And we have to realize that when we're confronted, either for ourselves or for our colleagues, we have to always start, like we do in trauma, are they dying now? And this does refer to the epidemic of suicide, of course, but I think it also refers to, is their soul dying? Is there meaning, their purpose? Are they just suffering, which is a form, I think, of soul dying? And so are they dying? That's the first question. I'm having trouble getting these to advance. Excuse me for 1 minute while I try to figure this out. There we go. The next thing is, what caused the injury and what is injured? Dealing with a patient after an MVA is very different than a gunshot wound. It's a gunshot wound to the head. We don't have to worry about the other organs. I mean, we know how to do this. This is a differential diagnosis. And how we're going to move forward is basically based on what caused this injury. So when I started thinking about it, it was like, we have gone through an era where it just seemed like everything was in one big bucket. We had burnout, and we needed to deal with burnout. And we got a lot of resilience training, and we got yoga classes, and people put bananas in the lounge. But really, I mean, I'm sure you all agree with me, that just didn't seem like the right approach. So as I started thinking about it, it's like, well, we don't, a gunshot wound's not the same as an MVA, the cause of all of this. What would be a paradigm be that might help us better? And again, I came up with this because we understand this paradigm. And what if we considered this paradigm of SEERS and sepsis and how we deal with critically ill patients in thinking about this new problem, this problem of burnout? So what would be in those buckets? When we're talking about etiology, the first one's self-care. So you'll notice it's the smallest bucket in my diagram, because if we don't understand now that you can't eat McDonald's all the time and you need to exercise and you need to take breaks, that's not going to fix the problem. But that is necessary but not sufficient. So we do need to keep repeating it. We do need to understand it. We need to teach our trainees, but it's not the most important. The two most important may be things you haven't really thought about. And the first in particular, I don't think people think about very much, and that's failure to recover from the injury. So a patient dies in the OR that you've known for a long time, and you have to go to the next case and you have to be on call that night. And we never, that's an extreme example, but we never get to recover. And then another one we really don't think about very much, which is the moral distress that this modern era of medicine has placed on us. And that can be personal moral distress, societal, as we certainly have seen recently, and institutional. So our institution's moral values are out of alignment with ours, and that can cause distress. And I've called this healer distress syndrome. And we now can sort of, you think about this as a new paradigm. This is kind of a beginning at etiology of diagnosing what's going on. What currently exists, though, for diagnosis is you kind of don't have it, you sort of have it, and you really have it. And I do think in the future, we're going to have to come up with some better diagnostic tools to say, is there burnout here? How much problem is there? How much distress? We right now are limited because we don't understand the severity of the distress, and we are limited in our ability to understand it by our ability to diagnose and stage this syndrome, which means how bad is the injury? How do we stage this problem if we're thinking about it in this new paradigm? This is something else we're good at in trauma. We actually understand how to say somebody is more injured than someone else. There's fairly detailed scoring systems for all kinds of things. What would it look like if we started thinking about physician distress, healer distress in the same kind of terms? In the progression from Sears to septic shock, for instance, what if it was like this? That stage 1 of healer distress syndrome was onset of symptoms of distress, usually mild. Most of us, most days, honestly, that we recover from. Stage 2, a significant sense of distress, decreased interest in people and events, increasing anxiety and fatigue. Stage 3 might look something like this: pervasive distress, moving into substance abuse or other high-risk behaviors, failing relationships, inattention to responsibilities. And finally, the end stage, stage 4, impairment due to substance abuse or other high-risk behaviors, significant breaches in professionalism and patient care, on up to the life-threatening suicidal ideation. If we think about our colleagues that are reported for professionalism and who are struggling in this paradigm, we may begin to think about how we deal with them and how we help them in a different way. Accurate diagnosis can help us triage the most severe to the care they need in a timely fashion. And what is that care? What is that treatment? Well, we actually know that from our trauma experience as well. It is resuscitation, and then it is to remove, decrease, or modify the source of the problem, source control, or stopping the bleeding, or whatever it is, and then supportive care. So I think this is a beginning, not a conclusion at all. I'm proposing this as a new way to think about it that will hopefully lead us to more accurate diagnosis of distress and burnout, allow timely and appropriate triage, direct the therapy, and maybe most importantly, provide a framework for research that lets us get better at this. So I thank you very much for your attention. And I'm hoping that now, having given you sort of the acute care paradigm, we're going to hear a little more about prevention and treatment from some of the other panelists.
Thank you, Dr. Brandt, for setting the framework model for our webinar today. If you have any questions for Dr. Brandt, please submit them to the question and answer box for us to answer later. Next, we welcome Dr. Hugh, the Assistant Professor of Surgery at Northwestern University's Feinberg School of Medicine. She's a pediatric surgeon and a health service researcher at the Surgical Outcomes and Quality Improvement Center at Northwestern. Dr. Hughes' research focuses on surgical education, wellness, and outcomes. She's the co-principal investigator of the second trial, a national study of the learning environment and resident well-being in 215 general surgery residency programs. She joins us today to discuss the culture and environment change needed to prioritize well-being and effective interventions at the individual and systemic level. Welcome, Dr. Hugh.
Thanks for having me. So a lot of the data I'll be sharing is from the second trial. Oh. All right, so as Dr. Brandt had just said, we're all really well trained in how to treat the injured patient. And we all, I think over time have become familiar with the fact that recidivism is high in trauma and that trauma is a little bit of a revolving door. So we all also are quite familiar with the idea that the money is in injury prevention for making a sustained difference. So tons of examples for this, seatbelt laws, helmet laws, gun control laws. They don't all have to be legal. Those are just all my examples. So analogously, how do we think about treating burnout? We've started a little bit to think about how to treat a burned out surgeon, but I don't think we've really quite conceptualized prevention. And that's because we haven't really thought of burnout as a systems problem. But the systems analogy shouldn't be totally foreign to us, even though we pride ourselves on responsibility and accountability for patient care. We've also realized that safety and quality are improved by systems approaches. So just like it doesn't help to shame a surgeon for having a retained foreign body, it instead is more helpful to think about the count or RFA tags or automated x-rays after surgeries. Similarly, we can think of burnout as something that is not the surgeon's fault. So we need a safer coal mine, not more resilient canaries. That said, I think a lot of there's been a lot of stigma around burnout. People are feeling that we're saying that they're not resilient enough is the problem. And so I just thought I'd present some data to walk through that. So there are some data about physician resilience. There's a recent survey of 5,000 physicians that show that they have higher resilience than the general employed US population. And there is a relationship between resilience and burnout. So I'm not saying that it's not important, it is. As resilience goes up, you also see that burnout goes down. However, even in the most resilient population, about a third of them are still burned out. On the AB site every year, we ask a survey as part of the second trial of all the residents in the country. And we, in 2018, administered an instrument to measure grit in residents. And we too found relationships between grit and burnout, thoughts of leaving the program, and suicidality. And similar to the prior paper, we also found that surgical residents as a whole are grittier than a comparable population of age-matched peers. However, therefore, we are already a highly selected population for grit, and it's really unclear that being even more selective based on grit would get us anything more meaningful. We're looking at fractions of a difference in terms of grit score. Moreover, grit's not validated as a screening instrument. If you use it for something really high stakes, like admissions or residency selection, you have to start to question social desirability bias. We're all really smart and we know what the right answers are supposed to be on these tests. We also don't know what it means from an educational perspective. So like, is a gritty resident necessarily a better surgeon? Do you trade off certain things for grit, like insight or empathy? And finally, grit is trainable. So in screening for it, you might be instead screening for certain past experiences and causing equity issues. So that raises the question, why not just train everybody for grit? That seems easier than the systems solution. And this is the answer that I've heard over and over again from our qualitative data from the second trial. It's this issue of pull yourself up by your bootstraps. It points the finger back at the resident. So it's not that resilience, again, isn't an important skill to cultivate, but it can feel that you're being blamed for your role in your own burnout. It can feel like you're being told you're not resilient enough, and then that just further propagates the burnout. So what should we work on instead? Look at what makes our life hard when we're working, i.e. the environment or the system. There are two meta-analyses of physician burnout interventions, and they both show that the majority of burnout interventions are directed at the individual. However, among the few that are directed at the structure of the organization, burnout reductions are greater. So it does seem like, as for injury prevention, this is where the money is. So what is in that environment? So for the second trial, we convened a multidisciplinary work group and adapted pieces of various existing conceptual models to make our conceptual model of resident burnout. And you can see on the left that the environment is described by these 8 domains. We call them domains. And these are filtered through individual meeting factors like grit or resilience to determine whether or not somebody is engaged or burnt out. And this has profound consequences, as Dr. Brandt just said, on patients in the healthcare system. To describe the different domains a little bit better, Lindsay Zhang, a resident from the University of Chicago, published this paper, which walks through each one. And I won't read all these to you, but you can see them pop up as we go through them. So the efficiency and resources domain, for example, describes whether or not you have effective support staff, helpful coordinators, protected educational time. Other domains include faculty engagement, meaning in work, resident camaraderie, organizational culture and values, work-life integration, workload and job demands, and mistreatment. We did some analytics on our ABSITE survey and these domains, and have confirmed this is these domains sort of hang together conceptually. And also Ryan Else, another one of our residents, did a logistic regression just showing that each domain is in fact independently associated with burnout. So they are all important. The other thing we did for the second trial was we traveled around the country and visited 15 different programs, conducted interviews and observations at each one. And I just wanted to share with you some lessons we've learned from all those places. So number one, ask what wellness means. Most places have done something, and we've seen a lot of flails. For example, one place we went to had found somebody to give free yoga to the residents at 6 p.m. on a weekday. And you can imagine why that didn't work. Yoga is not for everybody. Even people who enjoy yoga might not want to do it at 6 p.m. at work. They might have small kids they want to get home to see. They may have a class with their friends that they're trying to make. You can't really dictate how someone should be well. And having a voice and feeling heard by your organization is a really huge piece of wellness. Okay, number two, once you ask them what it means, you're probably going to find that it's not fluffy. I think, as this quote says, the problem is most yogas put tons of resources into gyms and yoga and that kind of thing, when really just misses the mark and makes people more cynical. I think that's part of the stigmatization of wellness in surgery, right? Is that there's this whole wellness industry that sells luxury crap, essentially. That's not what we're talking about. So this just takes us back to that first quote, that it's important to ask people what wellness is. All right, 3, that said, I think people could all be a little bit more open-minded. So this chair of surgery at one of the programs said when they did their mindfulness training, they were cynics, but everybody really got into it, and later relayed when they were able to use what they learned in their day-to-day life. I was hoping Dr. Labaris could talk about this a bit more because her expertise is in mindfulness, but perhaps on a subsequent webinar. I would say even the military has picked up on mindfulness, and we love military metaphors in surgery, right? We've all said we've been in the trenches in residency or been on the front line. We like to think that we're really hardcore, and wellness sometimes seems incompatible with that self-conceptualization, but actually even the military doesn't see it that way. We visited a military program, and they're one of the ones we were most impressed with. So there was a death while we were there, an unexpected death. And in the morning after the death, at their morning conferences, the program director asked about it. The residents decompressed a little bit about it, and he said, that's a really hard thing. And he reminded them to take the time they need and to visit the peer support office. And it was just this very public offering of resources and support that I think is pretty uncommon. But to them, it was such a no-brainer that you do it. They're so matter of fact about it. And I think that's a place where we can follow our military analogies and follow their lead there. We don't have to like sing Kumbaya. We can just do it. Wellness does not mean not wanting to work hard. So we hear a lot about, and this is related to that concept of being hardcore. We hear a lot about if you care about wellness, you must be lazy. Even more specifically, we hear about how because there's duty hour restrictions, residents should be well. But that said, I think that we're all surgeons and we like to work hard. So the first trial data in which residents were randomized to have flexible hours, meaning they could work longer shifts or take less time off in between shifts, showed that people that were randomized to that intervention, even though they noticed that they had decreased time for health and for family, friends, and rest, had higher overall well-being. So I think surgeons in general like to work hard. And as this quote says, if I have people who are happy, who like being here, they actually work harder. Wellness is also much easier than you think. So one program we visited had just instituted a once a month protected time for wellness, and it was free and yet so meaningful to people. We actually recommend that people start out with the basics. So in another program, one of the failures we saw was they tried to do this whole facilitated discussion series about wellness, but what people really wanted were lockers and better call rooms and meal tickets. So they were really at this physiologic and safety needs on the Maslow pyramid and not at self-actualization yet. So it turns out like better call rooms and meal tickets may be easier to get, and those small wins can then build momentum for the higher order work that's going to follow. 8, can't be another checkbox. So the yoga program was saying everyone would get emails chastising them for not attending this, for not attending their free yoga. I think, again, it can't be another thing on the to-do list. It has to be something that really is a resource. And finally, lead by example. And I hope that our subsequent panelists talk about this because I have learned a lot from both of them about how to lead an organizational change. The one example I have is when I was a first year on faculty, I went to the AAS fall courses and heard this talk about being a good citizen and a leader in your institution. And Chris Sonnaday gave this talk in which he slid in the slide talking about protecting your family time, which is not something he had to do. It doesn't necessarily fall on this topic, but I remember thinking, oh, family isn't something that we pretend we don't have so that we can pretend we want to work all the time. And it just blew my mind. And it also gave us really practical advice for how to do that. So put important things on your calendar and protect them. The last thing I'll say is sometimes leading by example is showing ugly things under the hood as well as the good. Sometimes showing those vulnerabilities can be important for subsequent people who follow you and who need to see that they're not alone in whatever they're struggling with. All right, and with that, I think we should get on to the next talks. Thank you. I'll take any questions.
Yeah, thank you, Dr. Hugh. We'll address questions at the end. Please put any questions for her in the question and answer box. And we appreciate all of the opportunities you raised around culture and environmental changes and opportunities for effective interventions. At this time, I want to welcome Dr. Carter Laveris, who is our moderator for today's webinar, and she is going to take over and introduce our next panelists and take care of our question and answer session.
Hi, everybody. I'm glad you're here. Sorry about being late. It's been one of those days. Anyways, I'm really happy to and honored to be moderating this today. So our next speaker is Lauren DeCapriel Ryan. She's an assistant professor of psychiatry, medicine, and surgery, and the co-director of the University of Rochester Medical Center Coaching Academy, where she also directs that resident wellness in general surgery program. In addition to her work with University of Rochester Medical Center, Dr. Caporeal Ryan maintains a clinical practice. She serves aging individuals, those with chronic medical illness, and their families. She joins us today to bring her knowledge and expertise as a clinical psychologist and specialization in physician-patient communication coaching, also interprofessional teams and clinician well-being, to reframing surgeon well-being and offer new perspectives to destigmatize negative associations with well-being. So welcome.
Thank you very much. It is my pleasure to be here with all of you today and to begin a conversation regarding the topic of stigma and how that is influencing our conversations regarding burnout and distress overall. The barriers to physicians that they face in help seeking regarding mental health are very similar to those that are faced in the general public, but also worsened by the fact that you have a lack of time and a lack of availability to access care. And that's furthered by the fact that there's often a lack of appropriate services or resources in the behavioral health world that understand the culture of medicine and what it is that you do. In a 1998 critical paper, stigma was defined as any attribute, trait, or disorder that marks an individual as being unacceptably different from the normal people that he or she is surrounded by, and subsequently elicits some form of sanction. Since then, 4 types of stigma have been identified, and I'm going to touch upon each of these as we go through the conversation today. For surgeons, stigma includes both perceived and real adverse consequences in their training or subsequent careers, and there are fears of disclosing mental health worries, never mind a formalized diagnosis, and a struggle really in shifting from doctor to patient role as a result of the culture of medical education where you're taught to be held to a higher standard. Occupational training also discourages personal displays of emotion, resulting in a struggle really for us to separate that idea of feelings from unprofessionalism. When I first began my work in surgery, a colleague said to me, "There's no crying in surgery." And I was able to look at him only 6 months into the job and say with certainty, "There is in my office." In a culture that says there's no crying, we create feelings of embarrassment, shame, professional failure, and really reluctance to seek help. And in a 2008 study, over 4,700 surgeons reported that they were reluctant to seek care because of the impact to their license. For many, there's also increased difficulty in exposing themselves around thoughts of self-harm or suicide. More recent studies show similar concerns. In 2016, Gold and colleagues reported on a study of 2,100 women, and of those, 50% indicated that they thought they met criteria for a mental health diagnosis. 6% who had had a mental health diagnosis were the only 6% to report it to the state board. Many state boards ask tons of questions regarding mental health diagnosis, history, and treatment. Between 1996 and 2006, there was actually a double in the number of questions that are posed on licensure renewal applications. The presence of these questions is further stigmatizing because it adds to the idea of one being reluctant to seek care. It's a structural stigma that's worth addressing. There's a recent study that actually demonstrates that over 1/3 of licensing state executive board members actually think that the report of a mental health diagnosis is enough alone to sanction a physician. While information about one's health is critical in terms of our duty to protect the public, the Federation of State Medical Boards has recommended the idea that we really shift the model of these questions, noting that history alone does not reliably predict future risk, and that our mental health questions should mirror physical health questions. Will a diagnosis cause impairment? Your organizations can also evolve how they ask such questions for credentialing and onboarding purposes. So how do we begin to change the narrative, making it safe to talk about burnout and mental health diagnoses, and making it care accessible and acceptable? Let's start with a framework, and I want to draw a little bit on what Dr. Brandt has offered already today and build from that. When we talk about mental health, if you turn to the literature, much of it reflects a mind-body separation. This historical separation has led to less education about mental health and substance use disorders in medical education, and a subsequent discomfort in talking about it, not only with patients, but with each other. The discomfort furthers a stigmatizing paradigm, and it puts the person who has a mental health diagnosis in the position of internalizing their experience as something perhaps of a character flaw. It often means that they deny even their own need for care. We can begin to shift that by emphasizing a biopsychosocial approach, instead really emphasizing the idea that mental health is like physical health, a result of dynamic interactions between your genes and environment, social determinants of health, life events, upbringing, culture, and so on. Our framework matters. We need to recognize strengths and resilience, and also recognize what the impediments to resilience are, often the byproduct of systems issues. We need to create safe spaces for open conversation and listening. Peer groups can normalize what the stressors are and allow for validation and empathy. These groups can also be facilitated by any number of people, including mental health professionals, to help lead the discussion and reduce the sense of stigma that might emerge. Peer groups are not about griping or accepting the status quo, but rather creating a safe space for people to bring their struggles forward. And in that space, our aim is to really help struggling surgeons identify what's happening. What has happened to you before? How have you coped with it? What brought you into this field in the first place, and how can we support you? Taking a trauma-informed lens in this way, as Dr. Brandt described, also lends itself for us to see the strengths in others, to identify their resilience, to help them problem solve and ideally thrive. But listening requires also peer preparedness, increased competence and confidence to talk to a colleague in distress. In a recent study, 87% of physicians who indicated they would yes seek treatment. Of them, there were 46% who actually met criteria for a current depressive episode, and their readiness and preparedness to seek help went substantially down. Self-stigma deepens our willingness to seek care and help. It means that we often withdraw from relationships. So how can peers, mentors, and systems prepare themselves to recognize the warning signs of burnout and other mental health concerns? Colleagues working closely with each other can substantially change the culture of an environment by approaching others with open-ended questions and caring conversations. Think about the number of times that you've heard somebody ask, "Are you okay?" When I ask that question, you might think, I'm supposed to say yes. It's a leading question and often can lead people to feel further shame if they don't feel okay. We want to shift gears and try to ask more open-ended inquiries. How are you? Now you might be thinking, I'm not trained to respond to somebody's response. That's true. So how do we shift that? Trying here is the most important thing that matters, but also working with our systems to explore how we improve ourselves and advance education, policies, and procedures so that we can create a responsive and safe environment is also a crucial step. Remind your organizations about the benefit and the need to destigmatize mental health conditions amongst your workforce. There are substantial costs to burnout. There's a 16% decrease in patient satisfaction. There's an 11% increase in medical errors reported by burnt out surgeons alone, and substantial cost to those that turn over pretty rapidly and actually very early in their career. As you initiate dialogues, be prepared with solutions. At URMC, the Physician Communication Coaching Program was established by Dr. McDaniel. And as an embedded coach in surgery, I have the opportunity to watch residents and faculty at the bedside and in the OR, and to think about their strengths and opportunities for growth. Our coaches will tell you, and the literature shows, a clear link between professionalism and well-being. It's essentially a safety net. We can identify when people are starting to struggle and label the behavior rather than labeling them. Coaches then can move people to supports and address problems before they become crises. For those in crisis, you'll often see that they go to friends or family for support. Those people also feel unprepared to address and respond to what is happening to their loved one. We've subsequently implemented a friends and family orientation. Our hope is to orient people, networks, communities to the culture of surgical training and the lifelong career that you have all chosen. How do they recognize anxiety and depression, and what are the supports and services in the community at large? In this way, we are connecting our residents and faculty to the community and the community back to them. And in all of those initiatives, hopefully the theme that you've heard emerge is that we're trying to normalize discussion. And I encourage you to think about how your own institutions can do that, integrating routine dialogue around health, trauma, and resilience. Before the pandemic had influenced our daily practice in medicine, ACS, APDS, ACGM, and others were having deep dialogue and meaningful conversation around how to address mental health needs of surgeons, with attention to learning environments and organizational cultures. In 2020, of course, COVID brought about new stressors, and so we're responding to those. But the benefit of COVID has been, it is forcing us to take a closer look around organizational culture, personal lifestyle and choices, and mental health, and initiate conversations. We're seeing an increase worldwide around PTSD and anxiety, and this is opening a door for us to have protected dialogue and normalize the conversation. This is not a conversation about how surgeons can do more, be better, or fix anyone. It's really a conversation about how surgeons and institutions and the community at large can come together to advance the well-being of this group. Think about workplace interventions that can be created as there's clear evidence that they reduce stigma in a pretty rapid way. I'd invite you to use the last year as a catalyst for change. Thanks very much.
Dr. DeCaparel, Ryan, thank you very much for sharing your perspectives on how you're viewing surgeon well-being, and then also how you're working to help undo the stigmas around this. I think that's really critical and fascinating work. Okay, so our final panelist joining us today is Dr. Taylor Real. Dr. Real is a professor and chair of the Department of Surgery at the University of Arizona College of Medicine in Tucson. Her clinical expertise is in general and pancreatico-biliary surgery, in addition to extensive expertise in comparative effectiveness and health services research. Dr. Real is an executive leadership coach. She trained at the Institute for Professional Excellence in Coaching. She applies her leadership training as a developmental tool to help surgeons and residents reach their full potential by raising self-awareness, developing emotional intelligence, clarifying their goals, identifying and addressing personal challenges, and consciously improving and integrating these things into many facets of their lives. She joins us today, and she'll provide insight into techniques and strategies to engage leadership in prioritizing well-being within surgery. Dr. Yao.
Thank you very much. So approximately 75% of physicians in the United States and 68% of surgeons are currently employed by hospitals, academic medical centers, or practice groups. And as a result, organizational leadership has a critical influence on clinician well-being and job satisfaction. Brian Bowman and the group from Stanford described 3 reciprocal domains of well-being, which are shown here. A good portion of the discussion on physician well-being and treatment and prevention of burnout has focused on personal resilience and treating the individual, as it has been mentioned. We definitely need to help individuals who are struggling, and I would argue that we need to provide these same skills and support before they're struggling. But without addressing the local and organizational culture and addressing the practice environment, this is not enough. Dr. Hughes spoke earlier about the importance of culture, and it's critical that we simultaneously create an intentional culture in surgery and in our organizations that supports the well-being of our physicians and staff. In my opinion, if you get the culture right, the rest is easy. Work RVUs, compliance, quality, patient satisfaction, because engaged, healthy surgeons with discretional energy can do all of those things. But that culture change takes time, and that culture change can't happen without the engagement of the leadership. And I'm here to talk a little bit about how we do it. I certainly don't have all the answers, but I'll share some of my experience. First, I think you need to help the department, the hospital, or administrative leadership understand the importance of physician well-being in everything we do. They need to understand that physician well-being touches every outcome that they are interested in: productivity, patient satisfaction, patient outcomes, culture and behavior, everything. And that investing here is going to pay huge dividends in everything that matters to them. Burnout has severe consequences on the individual, but also their organizations, their colleagues, their family, their friends, and the patients that they treat. So this has already been discussed, but burnout negatively impacts patient safety. For each 1-point increase on the physician well-being index, which means worse well-being, there's a 3 to 10% increase in the likelihood of physicians reporting major medical errors. This increase in medical errors further worsens physician burnout and is associated with increased litigation for hospital systems. It impacts patient satisfaction. When physicians give and give and give, and they don't take care of themselves, they have nothing left to give. It impacts their interactions with patients and other people, and it impacts patient satisfaction. And burnout results in high levels of physician turnover. So if you consider an organization that has 450 physicians with an annual turnover rate of 7.5% a year and a typical replacement cost of about $500,000 per physician, this organization would incur costs of over $5 million annually related to burnout-associated physician turnover. I think it's really important to advocate for system-level change. So at Banner, which is the University of Arizona's clinical partner, there's a system-wide initiative called CHIM, or Cultivating Happiness in Medicine. This effort's in its infancy, but the goals of the CHIM program are laid out here. And in the next few slides, I just want to talk about some examples and why this sort of thing is important. I think system-level efforts do many things. They demonstrate the commitment of the organization to physician and staff well-being. And at the same time, there are many pockets of activity to promote well-being throughout the system. And efforts like this can limit duplication of effort. So why invent something if someone else has already done it? And it allows for dissemination of best practices and things that actually work. And I would actually argue that we need to do this on a national level, sharing things that we've learned at our respective institutions and learning how to export it to other places. I think it's really important to systematically develop your team. So faculty and staff development programs are outward signs of the interfaith that institutions have in their workforce. And it gives physicians and people purpose, one of the things that keeps us from being burned out. These can be at the department or organizational level and should not be limited to physicians. These opportunities include workshops, individual activities, formal mentoring programs, career navigation, sponsorship, leadership development programs, individual coaching. At Banner, the system actually has an internal coaching-based leadership development program, and it's a formal curriculum that uses internal coaches who are assigned to physicians that are nominated by their departments. The focus here is really on aligning talent with strategic organizational needs. And it really invests in people. It provides a pathway for physicians in the hospital leadership, and it allows for networking and connections with the healthcare system. I also want to stress the importance of developing our leaders because we need more surgeons in leadership positions. So to get this message out, we need physicians to have a seat at the table. And this is different from a traditional academic path, but I would argue it's equally as important as the healthcare landscape changes. In a large survey of medical practices, there was a heightened sense of values alignment when those in the leadership had significant clinical experience, when they actually understand what the clinicians on the ground are experiencing every day. This has been mentioned too, but you need to encourage the organizational leadership to measure physician well-being. I don't have time to talk about all the different ways that you can do this, but there's a lot of different measures and it should really be a quality measure. There are many ways to measure it, but if you don't measure it, you're unlikely to change it. And I think one of the key elements is building a sense of community or support around people so that when we're providing them tools for individual resilience, they're in an environment that actually supports that. This can be done in departments and beyond departments. In our department, we had, at least pre-COVID, many non-mandatory social events. They don't have to come at 6 o'clock on a Thursday, but we sponsor runs and races. I recognize that not everyone thinks it's fun to run 13 miles. So we have a variety of other activities. We have book clubs, Halloween parties, dinner, Top Golf, anything that anyone brings actually will sponsor. And the CHIM program actually provides some of the funds to sponsor some of these events. We also created a shared space in our department, which brings people together. So during the COVID surges and for the holiday weekends, we provided food for the teams in-house and we keep it stocked with drinks and snacks. And I think, it's just a sign of making people feel valued for what they contribute to your department. I wouldn't underestimate the value of shared spaces and they make a huge difference. So Banner has invested in an operating room lounge and a physician lounge and resident lounge. And these are photos of that resident space. It's stocked with food and soda and snacks. And it actually is quite well used and it brings people together across specialties. And I think there is value to that. Dr. Hugh also sort of referred to a learning environment, but I think you need to really create a learning environment in your department, especially for surgeons. There's a pretty steep learning curve after training and throughout our careers. And adverse events, especially early in a career, can have significant consequences on a surgeon's confidence and their reputation. So you need to make sure that your junior faculty feel supported. You need to check on them even when they don't ask. You need to call them in when you have an interesting case. You need to destigmatize asking for help. So it is not at all uncommon for me to operate with my partners or ask them to come in when I'm dealing with something difficult in the middle of a case. And we make this the norm. And my residents who leave here are going to take that out into the world themselves. And then put support systems in place when the inevitable adverse events do occur. In Tucson, we have the Candor program. This is a program designed by the AHRQ to allow for a systematic response to adverse events. We also have a formal second victim program that we started in our department last year. This is a really good example of dissemination of ideas that work. So we didn't invent that. Dr. Kefrani and his group from Mass General Hospital came down, they trained our team in the department, and now we're expanding that throughout our hospital system and then eventually throughout the Banner system. Just a couple of other thoughts. I think, we all think about policies that implement or impact well-being. So examples are things like stop the clock policies for tenure or family leave. And I would urge departments when they're thinking about this, or institutions when they're thinking about this, to make these things opt out instead of opt in. In a 2002 survey of over 4,000 faculty members, 33% of faculty who were parents didn't ask for parental leave. And less than 20% did not ask to stop the tenure clock, even though they thought they would have benefited from doing so. So it places the burden on the person to ask when they're opt-in policies, and designing policies that are opt-out versus opt-in sends the message that the institution expects faculty to use the policies that are made available to them. As a leader, you can't just talk about this stuff, you actually have to walk the talk and sort of create this environment. And finally, this may address some of the questions that came up in the chat, and I can't address all the problems. I can't solve all the problems in the system. I can't eliminate the electronic medical record or documentation burden, but I can listen. I can understand the pain points that my faculty face, and I can address those, and I can chip away at it. So for example, I can advocate for scribes in the clinic. I can advocate for team models with the appropriate amount of physician support and physician extenders. I can change the time of conferences and meetings and be open to non-traditional schedules and so on. And when you really listen, these things go a long way. I think oftentimes the key is just creating an environment where people can come to you with issues and you can problem solve together, and you can be in a place that says, hey, if this isn't working, we're going to try something else. And if that's not working, we'll try something else. There's a million things I would have liked to add to this. This is just a whirlwind tour of some ways to engage your leadership in promoting physician well-being. And I am happy to take questions in the last few minutes. Thank you.
Great, thanks, Dr. Rial. And thanks to everyone on the panel for just sharing their work and research and insights, helping us reframe this central, pretty critical issue that we're all facing. There's a few really great questions. Some I think I'll just throw out to individuals. If you want to pass on it, that's fine. But I think, Dr. Rial, this might be a good one for you. One of the questions is, how do you approach an institution, whether it's a hospital or a medical school or other, to change the paradigm of how people think about wellness or resilience away from being either the responsibility of the individual or the responsibility of the institution, and coming towards this understanding that it's really a shared responsibility, especially because it seems like in the literature and discourse, there's a lot of heated feelings about the either or approach. So how do you go about that in concrete terms? What do you do?
I think it has to be sort of an ongoing conversation. When I think about any conversation with anybody, but with my leadership in specific, I think, well, what are the things that are valuable to them, and just helping them understand the impact of physician well-being. But then it has to be a partnership. I approach the conversation oftentimes by doing things locally, sort of showing that benefit, showing how that can benefit the institution as a whole. And I think we make progress really slowly and really steadily, but you have to help them see the impact, and it has to be a partnership. I think if individuals don't have those skills, even they're not going to do well in any organization. So it has to be both.
If I could add something to that, one of the things I think really helps the most is maintaining a sense of curiosity. I don't believe that there's any administrators who come to work to do a bad job. If they just literally do not get it. But it's not that they don't want to. And they are under huge stresses, financial strain and reporting to people above them, and spreadsheets, which none of us like unless we're doing research. But it's important for us to go to them and say, look, I know you have incredible stress on you. I just want to open this conversation. And then I think the chipping away thing at it, Taylor, is key. You actually have to be a little persistent. You have to just kind of keep, little text and pictures, and we had this issue today, and can I come talk to you? And just keeping this conversation open, but with a lot of questions. Like, what is keeping you from doing this? How can I help you? I know this is something you want to achieve. And I think that goes a real long way.
Thank you. So related to this, Dr. Hu and Dr. DiCaprio Ryan, another question we got was if you could please comment on differences between sponsorship, mentorship, and coaching, and how might these differ in terms of how they're applied to promoting surgeon well-being, or even Dr. Hu, if you could maybe speak to how these different approaches might be differently received in one culture versus another.
I was actually going to say Dr. Rael could comment on coaching since she's a professional coach as well. But as I understand it, the difference between mentorship and sponsorship has to do sort of like with the depth of the experience. So somebody can, how can I put this into words? Mentorship, I think, is a little bit of a two-way street. Like they get something from you and you get something from them a bit. Sponsorship is like, I have this opportunity and I'm volunteering you to take that. It's not necessarily like as much an investment as much as it is like a sharing of opportunities. Is that how other people understand it?
I guess I see mentorship as, hey, this is my experience, and, having someone benefit from, my previous experiences. And I think of sponsorship as sort of taking that one step further. So that's when I say, hey, and I help them do that. You're putting people for major national positions, you're sort of advancing them in the field. I guess I see it as a little more active role. And I think I view coaching completely differently. I view coaching as a developmental tool. And, a coach is someone who's not invested in me at all. So my mentors have some investment in me being successful, right? A coach is someone completely independent. And they're saying, hey, Taylor, this is where you are now. And this is where you want to be. And they coach that gap. They help me get from where I am now to where I want to be. But really, it's my agenda without interest on their part. So I guess that's how I see it. I don't know, Lauren, if you see it differently.
I completely agree. I think my role in surgery is to be objective, right? I'm not concerned about the technical skills. I'm there to provide expert consultation on communication, being, and leadership, and those other skills that are going to make somebody hopefully formative into a leader. Coaching is about behavior change and growth. And for us, what that means in our program is to see where somebody wants to go, and for us to have some ideas also of how to get them there, and to balance out the individual learner's needs while also offering what we know can support them. And so coaching is, I think, just like mentorship, also very tailored to be one-to-one with intentionality around that growth. But I think objectivity is the key.
So maybe putting it specifically in the context of well-being, what I'm getting from you guys is perhaps sponsorship is me reaching down to someone who I'm above and pointing out to leadership or their leader that they need well-being resources. So like speaking on someone's behalf. Mentorship might be someone who's lived longer or gone through something before me, helping me understand how to get through this and live a life that's healthy. And then coaching might be literally somebody who's standing beside you, giving you, constructive feedback or criticism so you can change some behaviors. Okay, well, this kind of segues into another question, which I think is up for any of you. Maybe Dr. Brandt, you want to start on this, which is audience member asking, would we be better off rather than intervening after the fact, trying to start off people with these skill sets in a formal fashion before they even take on their residency training slot?
Oh, that's an absolute yes. I mean, in the paradigm of, I don't want to fix gunshot wounds, I'd rather stop the injuries in our society. It's a little bit the same thing. That may be an extreme example, but yes, there are tools, there's toolkits, and that kind of goes back to the necessary, but not sufficient. We want to make sure that everybody has access to all of the things that can help their behavior, their own growth, their own health, their own wellness. So giving them that toolkit very early on, I actually think in medical school, even prior to residency, is critical. So yes, absolutely, prevention.
Does anyone else have comments about how that might be fit into not only medical school, but actual residency training? Like
I'm going to add one little thing to that. But if you remember in the paradigm, that part is tiny, right? So we can give individuals tools, but it does not address the moral distress and the systemic issues. That is a totally separate thing that we also have to address, the culture of where they're going to train. So yes, but would be my final answer.
And I still think it's critical, though. You know, I came to coaching through my own personal experience with burnout, and I wish I had those tools in my pocket. You know, our residency leadership and resiliency program is designed to provide residents those tools. And I think I reach some of them right away. I may not reach all of them, but, you know, I hope that when they get to a point when they need that, you know, they've been exposed to it and they get there maybe faster than I did. Right. And I know it's succeeding when I have a resident who felt comfortable coming to me with a really serious substance abuse problem before it impacted his life. And we were able to kind of change the course of that, you know, and so I feel like, you know, this kind of program and teaching those skills early, you know, allowed that kind of person to get help before it became something that ruined his or her career.
I think that toolkit also begins to reflect that the culture values that and is creating space and respects the fact that we do have to have that self-care as a component. And I completely agree with Dr. Brandt. It's a small component of a much larger issue, but in creating space to say, hey, we're talking about this, it's more acceptable. We've had the experience with our orientation to families at the beginning of residents coming forward and saying, my wife said I need to talk to you, because his wife knew that I existed, or her partner knew that I existed, or the parent did. And so it's changing the dynamic. And so I think as early on, definitely in medical education, as soon as we can, but at residency to also say, this is a culture that respects you, the whole of you. You have just committed your life to us for the next 5 to 7 years, and we're going to give you the community resources that you need.
So this is kind of a combination of several questions, but what do you all think about means and methods for measuring our impact or measuring where impact is needed? So questionnaires or scales that help guide individuals or organizations in terms of the status of well-being at that site or with those people. And then what should those measures contain? We hear a lot about compassion or empathy or emotional intelligence, or you name it. What are you seeing from your experience, your research, your reading, your reconceiving of things about what measures matter and how we should do those measures?
The short answer is it's complicated. So probably the most well-established instrument for burnout is the Maslach burnout inventory. Recently, there was I think it's a review paper in JAMA. It's written by Rottenstein and et al. And it describes how in the literature, there's like 47 different interpretations of the scale, meaning there's not a diagnostic threshold by which you can call people burnout or not. So it's a little bit tricky to compare yourself to other populations in the literature when everyone is using different definitions. So, so for the second trial, what we do is we benchmark you against other programs in the country, and it gives you that reference point. So at least among surgical residencies, this is where your residents stand. If you're doing it on your own, it's a little bit more difficult. And there are a lot of different papers that you could sort through to figure out like where you want to do the math. But that doesn't really tell you what's proximal, right? Like burnout is the end of the pathway, and what you want to know is more like how to affect that change. And I think a comment that both Dr. DeCaprio-Ryan and Dr. Ryall commented on in the chat is that focus groups, I think, will give you that data. It's actually what we recommend after we give data back to programs from their ABSITE surveys. We tell them you should talk to your residents about what this means at a really granular level and what's going to resonate.
Anybody else want to tackle that one?
Well, I think that, you know, in the paradigm as I see it, I mean, for those that aren't pediatric surgeons, you know, the scale for whether or not a baby has necrotizing enterocolitis is a 3-point scale. It's like you might have it, we think you have it, and you're dying. Unfortunately, I think a lot of the scales we have to measure this, not only are they extremely confusing because they're being interpreted so many different ways, but they're not detailed enough. And part of it is that how do you, if the causes are all different and it's so complex, and you're ending up measuring an individual in a system, we've just got to get a lot more refined. We need a lot more research to figure out what the scale should be.
Yeah, agreed. And then I hope we have time for this because I think it's kind of the elephant in the room, but a few people have either commented on this or asked questions about it. How come you're all women? And how come so frequently when we talk about this subject of well-being, everyone who's championing it or discussing research or solutions are women? And as a corollary to that, could you comment on the support or reception that you get from male colleagues, either in terms of buy-in or disagreement with these ideas or these approaches?
I'll just say
So
that
I would go ahead.
I was going to say 2 of the biggest champions in our department are men, and reached out to me for help to really initiate things around wellness content. My job was first on communication and leadership, and then they said, "Hey, can you do this thing?" I think it's very different. There's an additional layer of stigma there that I didn't talk about. It's more acceptable for us as a group of women to have these conversations in the way that we have gender bias around emotion and affect. But I think that there are a lot of men out there who are champions and need cheerleaders and advocates to work with them.
Yeah, I was just going to say the same. There are many men who are leaders in this field. They're not sitting on this panel today. And I have seen absolutely no gender difference in the need for it or the receptivity to it as we introduce these ideas.
And I think we could do better. I think we probably should not have had all women on this panel because all of us have the same experience. And I think we are all so involved in diversity issues as well that we just messed up this time.
All right. Well, I think we're over our Q&A time, but thank you very much to the audience for all your great questions, for attending, for giving us your time. And then, of course, to the panelists, again, thank you so much for your work, both in your thinking and your research and in your presentations today.
Thank you all so much for joining us. To conclude, we just want to thank all of our panelists and our moderator today. This video will be available on demand, and we will send an alert when it is up on the FACS website. And if you'd like to keep connecting in with the Surgeon Wellbeing Program at the American College of Surgeons, we have a webinar coming up on Thursday, February 18th, focused on managing microaggressions. You can always connect with us on social media as well. On the bottom right-hand corner of your screen, you will see the ACS program contact information for the staff, for Kathleen and myself. If you have any questions from this webinar or looking to connect further with any of our panelists, please be in touch. We thank all of you for joining us and all of our panelists for being with us today. We hope you all have a wonderful afternoon.